We are very excited today that we have you with us on this show, Dr. Seema. Uh, you are not just an OBGYN, but you've also done a DM in genetics that makes you one of the very, very few people who are in the fetal medicine space, but you're one of the most renowned persons in this space, not just in Delhi, but across India as well. So welcome to the show, and we are so happy to have you with us today.
Thank you, Dr. Anu, for inviting me. Really looking forward.
Same here. So I think a lot of people want to first know who you are. Why did you become a doctor? And you not just did become a gynecologist, but you also ended up doing a specialization in genetics. That too many years ago. So can you tell us a little bit about who inspired you to become a doctor in the first place, and why did you pick genetics as your second degree in this space?
So, basically since childhood, the only career which I could think of, during those times, was being a doctor only. So I had no second choice. I had never thought of any plan B. And, so when I was growing up, my family environment was also, like service like thing. Like they were the background of, the police, army. And so those who are serving for the nation, the freedom fighters. So, you not only require the academic skills to survive in this branch, you also require the temperament. So while I was growing in my childhood, the temperament automatically, along with my, desire to become a doctor, because this is the branch where you can do maximum benefit apart from the army services, maximum benefit to our country. So with that wish, I tried to enter into, and I cleared through my exams, then MBBS, then MS Ops Gynae. I selected that because I thought I can do more better to the women by being a woman and working in this area. So after I finished my MS in Ops Gynae, in search of job, I reached SGPGI Lucknow. And I had never imagined in my dreams that I would get to know something in and that was the Department of Medical Genetics. So I came with the intention that they will be doing the gene therapy. So my first question to them when I appeared for the interview, that do you do the gene therapy? But then when I started working there, first as a SR, senior resident, then I realized no, they are doing something different. They are doing prenatal testing, which automatically from the obstetrician background, you have always, wanting to do the prevention kind of things. So this I realized, oh, this was the branch which I was looking for. And so I decided to settle down in this area. And gradually from after I finished, I came back to Delhi and I pursued through this prenatal diagnosis, genetic counseling, and met everyone and trying to make the difference to the society through the the children being born, fetuses. So
So this was how many years ago was that you did
uh,
genetics?
this I joined in 2001. The same year, the
Wow.
Human Genome Project was launched. So, lots of curiosity and, with lots of expectations, actually, I joined this branch. And gradually, step by step, I came to know what this is all about. So, it's the journey has been, quite thrilling and quite fulfilling and enriching towards my career. So,
That's quite interesting because I think 2000, 2001 was the time
yes.
I started my first company as well. So
Oh,
we've
okay.
been in this.
So we are contemporary. Yes,
Yes, yes,
great. Good to know.
yeah.
Yes.
So I think when you must have started doing your practice in the prenatal space, clearly I think technology at that time was not as well developed as it is today. So what were the most common kinds of tests, and were there any specific areas that people were looking at in terms of what kind of diagnostics where people wanted
Yeah,
at
it
point
was,
of time?
as you rightly pointed out, there was lots of, lack of awareness, lots of gap.
Mm.
What all can prenatal diagnosis can do, how this can help, who are the women who will be needing this. So initially when I started, it was more of, that I had to, inform my obstetric colleagues that where these tests are needed. It is also the low risk women who will be needing the prenatal testing through amniocentesis for Down syndrome, even the carrier testing for thalassemia. When they are identified, the CVS will be needed. So initially, there was a lot of gap between them and us, so as to identify the reasons that for which they would refer to us, and we will pick up from those low risk women that who will require these prenatal testing. So the number of diseases for which we were doing initially was prevention of Down syndrome, prevention of thalassemia, and a couple of prevention of hemophilia, Duchenne muscular dystrophy. But gradually, when we moved into this, and gradually when the genomics started coming, there are lots of other indications started coming, like NIPT entered, and it was a game changer, as you know. Everything was non-invasive. We were trying to shift many of the, and it is popular among both the obstetricians as well as the patients, because this is being non-invasive. So this was a game changer. So for quite some time, the indications of the positive dual or this reduced, but then came the positive NIPT, and we started doing for that. So now with the genomics, so many single gene disorders being identified, which I can't even imagine of when I was doing my all these. I had just a couple of, maybe 10, 15 disorders which I knew, and I was doing them. But now the advantages are, the numbers are huge for which I can do. I can say as number as present in OMIM.
True. I mean, there are more than 7,000
Yeah.
rare conditions known.
So if I can identify them, the challenge is to make the diagnosis in the index case first, and then followed by the prenatal diagnosis. So
one of the big challenges that we also see is that you know when when a doctor who's maybe not a fetal medicine doctor, but I mean in general, let's say a gynecologist or somewhere who is not very used to genetics or looking at a phenotype for genetics, when they send samples, for instance, I think the detailed phenotype is usually missing, right?
Yeah, it's missing.
Was that a problem from the beginning, or was that mostly people just say, you deal with this patient and they
So
talk?
initially they were referred to us for everything. It was not the obstetrician who were doing this much. So we were the one who were making all these HPO terms and making the prenatal testing. But with the increase in the number of the fetal medicine specialists, these are the obstetricians who are trained in the fetal radiology and the interventions. So this trend came up, and they do deep phenotyping, but at the same time, some of them are not that much trained. So that came up. But the biggest challenge for us is the fear of abortion, which the obstetrician also has got, and the general public alike. Both of them, they think that this procedure is very, very unsafe. There will be 100% risk of abortion. So, actually we had to, much of the work to be done, and rather, it was like proving ourselves, while doing this procedure, the risk of abortion is similar to the other countries, like 0.1 to 1%, which is very, very minimal. It's we used to tell them like it's similar to crossing a road. It is as similar. Yeah. So so from that time where there was acceptance of the amniocentesis, maybe we can say 50%, 60%. Now almost more than 90% of the women will be willing after the counseling. And of course the obstetrician plays a biggest role. She is the decision making in this prenatal diagnosis multidisciplinary team. So she is the decision making. So the patients will look forward, the pregnant women will look forward upon them only. And now they have realized, obstetricians, that the procedure is reasonably safe and their patients can go ahead with the procedure. So that was the thing. Then the diagnosis, the index case diagnosis was another challenge, where the patients would be referred to do the prenatal diagnosis in the ongoing pregnancy, during pregnancy, without index case workup. So we had to tell them that no, we first require the index case. These were all high risk cases. So gradually all these gaps, they are lessening, and we are doing more and more, the focused work, where we really need our, the that what tests to be required, then how to interpret these tests, then when to offer. So now we have from that era that, convincing them, diagnosing, first telling them which are the indications, then telling them, no, no, abortion is okay, it's very, very minimal. So from that, now we are focusing mainly towards the prenatal diagnosis so it has been a significant change over the years.
So now there's a lot more acceptance, both in, I think,
Yes.
also in the mind of the patient, but also in the minds of, I guess, the obstetricians as well
Yes,
as.
yes, it's more in the minds of obstetricians. So because if you're not doing any procedure, like even I see that if something I don't do and somebody asks, then for me everything is scary. So
Mhm.
for them also it is similar, that because they are not doing this procedure, so 0.1% or 1% seems a bit quite a lot for them. But gradually when we told them, we proved them that no, it's minimal only. So then
So if you had to describe like what a fetal medicine expert does to an average person, right? Like maybe not to a doctor, but to somebody who is
yeah,
pregnant, right? How
yes.
would you explain to them what
Yes.
you
So,
typically?
the fetal medicine is a new addition to the reproductive health. And during pregnancy, there are two patients, like one is the mother and one is the fetus. So the maternal care, the obstetricians are, well trained for the maternal care. And initially, the fetal care was also being taken by them only. But gradually, with evolving, rapid advances in the fetal medicine techniques, the radiology techniques, fetal intervention, genomics, the field has advanced so much that in the current times, any pregnant person needs care of two specialists, maternal and the fetal medicine specialist, and both should work together towards the ultimate benefit of both the mother, so that at the end of the pregnancy there is a healthy mother and a healthy baby is born. So because of the technical advances, our obstetrician colleagues, they cannot cope up the advances, and all these advances are beneficial for the pregnant women. So it's high time that all the pregnant women should see a fetal medicine specialist during their pregnancy time,
And
along
it
with their obstetrician.
and let's if all could not see, but there are a certain set of people, for instance, the ones who are at a higher risk or otherwise.
Yes, definitely. And also, here I would like to add that, in our country, the, the fetal medicine specialists are many.
Mhm.
It's not that the obstetrician who are fetal medicine specialists, it's also few radiologists, they are doing quite a good job. So they are also fetal medicine specialists. Some of the medical geneticists, those who are obstetricians, they are also doing good job in the ultrasound, fetal intervention. So unlike other countries where only the obstetrician is doing the fetal radiology and the fetal intervention, in our country, and I'm happy with this because our country is vast. So only few fetal medicine specialists cannot give quality care to these fetuses. So I'm happy that this is in the hands of everyone, and many specialties. So that we can, our population is huge, so they need more specialists.
So if a young student today has done an MBBS and done could have done a PG in radiology or in obstetrics, and
Yes.
can then do a fellowship, or what do you want?
Yeah, yeah. In India, there are few centers which are offering fellowship in fetal medicine for 2 years or 3 years. So these are the centers which are, giving this fetal medicine, but they are not recognized by the Indian government as yet. So, but these fetal medicine specialists are there. The trainings are available through the private centers.
Oh, got it. So it's not yet something that the government has.
Yeah, the government are giving the high risk pregnancy, maternal fetal medicine, that type of, the degrees, but the pure fetal medicine, diplomas and fellowship are available with the private, hospitals.
And when you look at like all your lot of the cases that come to you, I'm sure most of them are difficult cases, and people send them to you because you are an expert in that. But do you also find people who are coming to you, like you said, everybody should have a fetal medicine expert as well. So has the awareness increased so much that there are more people who are coming to you as a general pregnancy?
So it has
About.
not happened as of now. because public is not aware. So mainly they are coming to us through the obstetrician route only. They go to the obstetrician, and when they find some difficulty, then they refer to us. But our dream is that it should be a routine. Like during pregnancy, the patient should visit two doctors.
Mhm.
They should know, like the now earlier cardiology was not a different branch, it was associated with the medicine, but now everybody knows that I have, for some these chest pain, I have to visit directly cardiologist. So that much awareness is still lacking, and more so in northern part of India. So this will take some time, but I'm sure that will be done, because it has been tremendous advances in the the, and which will help the, if you miss those, the the some there will be a big challenge for the family. So it's better that the public is aware, becomes aware sooner the better.
And also, I guess we need to have more people, not just in the bigger cities, but in
Yes, the
parts.
tier 2 and tier 3 cities, yes,
Yeah.
they are already there, they have started going there, but the awareness is not there, so the public is not reaching to them, either to the even metros also. They're not coming directly to us.
Okay. So there's still a lot that we
A
need to
lot to be, yeah, to reach the public. It requires, I think, a lot to reach the public.
do.
And because this is a branch more or less, talking about negative outcomes, so that does not get, publicized much. They are, so I think the positive outcomes only would come more, na? Because whenever I want someone to share all these things, they would say, no, no, I would not like to share anything with anyone. I don't want anyone to know about my genetic status and all. So I think there is lots of, stigma related to all these. So that's why, they are not reaching to the public.
But there are also many, you're solving and giving lots of people joy by solving some of
Yes.
the most difficult problems, right? So it's not just, it's not just that,
Yes.
you're looking
Yeah.
at,
Yeah.
so
Yeah.
can you give some examples of, how your intervention have made people have nice, the right kind of babies and healthy babies? So what are the kinds of maybe, why should they, like, if they were to come directly,
Hmm.
there may be some people who are lacking in certain kinds of things, or they might end up with a unhealthy baby if they if you didn't intervene during
Yeah.
the pregnancy, right?
Yeah. So basically, we want a preconception counseling. So any couple who is planning a pregnancy, they should see us to understand what is the right age for the conception, because over the years the age at marriage has increased, and public, I have realized that they are not aware that the most ideal age to conceive is 25 to 35 years of age, and 25 to 30 practically, more truly. So many of them are unaware. Then there are, certain drug exposures, certain medicines which should be avoided. Certain medicines like folic acid has to be started preconceptions. Then there may be some family history, there may be consanguinity. So all these things will be better if they see us during the preconception. Then also during the early part of the pregnancy, and where we would like to screen for the infections, then family history, and basically women low risk where there is no family history, or it could be a high risk. So even the low risk women also, they should see us, because the majority, as you know, you are also working into the genetics, as you know, 90% of the genetic disorders will happen without family history, like Down syndrome, it happens sporadically only. DMD, that happens sporadically. Thalassemia, hemophilia, there could be a family history, but in autosomal recessive, the family history will not be obvious. So basically, that is also, not running across the generations. So the we need to, identify, from the history, from the blood investigations, so that we can give all these benefits to maximum number of women as much as possible. So the Indian guidelines would suggest two common genetic disorders, the thalassemia, and currently the SIMG, the Society of Indian Academy, they are also advocating the preconception spinal muscular atrophy screening. So by all these, the common genetic disorders can be screened, they can be prevented. So as you know, most of them have a very, difficult, mental sub abnormality, then physical. So it becomes a big burden. So, like,
Because I think that's the time when also there are many changes, not just genetic, but also epigenetic
yes,
changes that are being
yes,
impacted on the
yeah,
baby. Yeah.
yes.
And people don't give it importance. They say, oh, I have to take so many medicines like folic
Yeah,
acid and all that. But I think that helps in prevention of
yeah,
certain
yeah.
neural tube defects and many other things, right?
Many other abnormalities, yes.
So I
So all
think
those
people
things
need
are.
to understand that, doctors are not just forcing you to have these
Yeah,
vitamins or
these are
something.
important.
Yeah,
Yes,
they're very
very
important.
important.
Yeah.
If you don't take, then there are chances of abnormalities. Not all will get, but these are all preventive steps only, so as to have a healthy outcome for the fetus and the of course the mother both.
So,
So it has to be, the pregnancy has to be planned,
correct.
and they need to know when to plan, then what are the medicines to be avoided, what are the medicines to be taken, what tests should be done before pregnancy, so that they are aware that these are not transmitted in the fetus, so as to have a healthy baby at the end of the delivery. So that is what we aim for.
That's absolutely wonderful. So I was listening to one of your other, videos, and you had mentioned that NIPT can be done for a large number of people, but you'd also mentioned that for some people you don't recommend it, right? Which was I thought was quite interesting. So I mean, it would be interesting if you could tell
Yes,
when
yeah. So
someone
actually,
do, and
I
what, first of
advocate.
all, what is NIPT? Because
NIPT
we
is
understand, but
actually, yes, NIPT is one of the biggest, the technology as far as the genomic testing is concerned. It is the most powerful and the effective technology in my lifetime, which I can see, and I really admire that how few fetal cells in the maternal circulation can give rise to the diagnosis of Down syndrome, and 70-80% times they are correct. Initially when this test was introduced, and I said, see, how is it possible, and how much difference they are going to make it. So we are already doing through ultrasound, through double marker. I don't think that this test is very good, but slowly when this came into the practice, and I realized, oh, it's a wonderful test, wonderful technology. So this is a non-invasive. The principle is that the fetal cells are circulating in the mother's blood, and so from that they would be doing the doses analysis, that whether it is Down syndrome or trisomy 18, and if it is high risk, then for the amniocentesis should be done to reconfirm that yes, this is the fetus is affected with trisomy 21 or trisomy 18, and then the family can be counseled. So I'm one of those who would say that it should be offered universally. Everybody, provided there are some which restrictions, that if there are some ultrasound abnormality like some cardiac abnormality, or there is some increased nuchal translucency, binder facies, and so all these ultrasound abnormalities, the NIPT should not be done. Then NIPT should also not be done when we keep doing dual marker or quadruple marker. So if the PAPE is very, very low, zero point 0.1, because these all indicate some atypical aneuploidy other than the common aneuploidies of trisomy 13, 18, 21. Then if the mother has received blood transfusion, or if she has undergone the bone marrow transplant in the past, she may be 46XY from the because of the blood, the bone marrow transplant. Then, or if she is having some malignancy, there will be multiple abnormalities which will create confusion. So all these are situations or relative contraindications where I would say that this should not be done. Otherwise, generally it's a very good test, and it can be offered probably not only to the advanced maternal age, although we say that the Down syndrome is more common in the advanced maternal age, but two-thirds of the Down syndrome are being born to the younger mother only. So it's high time that we should at least offer them, because later on when the baby is born and they would tell us कि हमें तो बताया ही नहीं, I would have spent this much amount of money, 10,000, the cost has gone significantly down. So it is within the reach of all the Indian middle class which I look after. So for them 8 or 10,000 is not a big amount. So I think one should at least inform them. It's an informed decision making. It's for them to decide whether to go ahead or not. So it's a wonderful test, I must say.
if two-thirds are already are young, then shouldn't the guidelines be changed accordingly to sort of make everyone aware that it can happen in a younger age as well?
Yeah, they do say like uh, but they do say that this is common in younger mother, but they are currently NIPT not offered to, but in some countries like Netherlands they are doing for the whole population. The government is doing rather whole genome NIPT rather to talk of five common aneuploidies. They
Mm.
are doing, so few countries have started doing NIPT as a genome wide and to the population level, and the results have been remarkable. So they not only diagnose the Down syndrome and all, there the atypical abnormalities which could have influence on the, so but it should be introduced at a larger level, and the cost is not prohibitive these days. It is quite cost effective also.
And so I think it should be left to the
Yes.
parents to decide. But
Yeah, they should be informed.
is there what percentage of people, after knowing that a child has a possible, like the fetus has a possible chromosomal abnormality, uh, are there still some parents who would then take the decision to keep to keep the child, or would that be something that normally they would abort, or how?
Yeah, over many years, it has been about 25 years into this, doing the prenatal diagnosis. And I would only remember one mother who voluntarily took this decision that she would continue a baby with Down syndrome. The reason she gave, that I'm 40 years old, and this was a time in, maybe you can say, 2007 8, so it was long ago. She said, I'm already 40 years, I'll not get another second chance. She had suffered many abortions, so she said, I don't have any baby, so I'll be happy to take up this baby. And she continued with that pregnancy and delivered that baby. But otherwise, majority, when we talk to them, they would abort only, because nobody wants to have a baby with mental or physical subabnormality, because it's a big burden. And working in this area, this burden is not only for that person who has got this, for their family, for their family members, and for the whole generation. They suffer all the time. They are, so their life changes drastically. So it's better that if they are taking this decision voluntarily, that they don't want to go ahead with this pregnancy, then I think they are right in. And after, this is all informed decision only. So
That's
many of them want to, explore further, that is there any treatment available. I'll get a call from, South India, different places, that my fetus has been diagnosed Down syndrome. Can you suggest, is there any treatment available? Many of them would want to continue, by other methods, that whether there is some treatment. But when they get to know that there is no treatment, we don't have any treatment which can remove the impact of one extra chromosome, and then they would abort. So not very easily they would afford. Many would make an effort that somehow they can save that pregnancy, because as you know, pregnancy these days has become a challenging issue. Many of them marry late, then they will have infertility, then they will have IVF, so with lots of
you are always dealing with very tense patients then. I think people who are
yeah.
it's a good thing, having a baby is a wonderful feeling, but I think
Yes.
you're also anxious with, the
Yeah.
health of the baby. So I think it is you have double lots of emotions to to take
Yes, yes,
when
yeah.
you
You
are.
have to, many of them would, just come out of from emotionally. It's very, it takes maybe one simple session minimum is in talking to me would be around 30 minutes with a parent when such a diagnosis is. Then there will be repeat also, they would, somebody would want to clarify. So it's not as easy as we think, that we will explain them that this is a disorder with mental retardation, with cardiac abnormalities, and go ahead with the termination. No, they will like to understand, they will like to bear that pain with someone who can understand their feelings, that what all is about. They would like to listen from other parents, those who have these children. They would like to connect to them, that before I take a decision, can you connect me to few parents? And sometimes it's not only about Down syndrome. Sometimes because the genomics and genetics has advanced to such an extent, that we get to find out something which will be entirely normal only, but the prenatal diagnosis has told them. And more dilemma is on those cases that what to do, because there is a problem, but a doctor is saying that there will be hardly any problem. So those parents, they seek opinion from those parents, those who have a baby with this. So it's a, these counseling sessions are quite, you know, exhausting, and the parents are quite anxious, worried, to take a decision. It's a very hard decision, that the pregnancy which they wanted, that they don't want to terminate, at the same time they don't want to continue with any abnormality. So these
So how do you, I mean, I think take care of yourself with, so much of the emotion, that load that you take from your patients?
Yeah, sometimes I also get carried away, but I think, at the end of the day, I feel that, at least I have been the feeling, that I have been able to help the family. I know, because I can see the future. If there is any baby with the mental subabnormality, how the life becomes. I have also seen how the society behaves with them, everything. So I know that it's tough for them at in the current time, but the future, it's a problem of short lived. Gradually they will be able to overcome this challenges, emotional challenges. And I do see that, thanks to our society, that they keep talking to their family members, their friends, and gradually within maybe a month, within a year or so, they will come back to you that now I'm again pregnant, and then they will have a healthy baby. So the I also share those joys also along with them. So that is a, but I don't feel that I get matlab, affected by them, but yes, I get carried away by them in that flow. But I try that joy, that probably I have helped them, that keeps me going. And long ago I had a patient who asked me that she had a baby with a mental subabnormality. And she asked me that, ma'am, how long this baby is going to survive? And that day I was, oh my God, this lady is in such a big pain. So I must continue to do this area, work in this area. And that was a time when, there was lots of, unawareness moving here and there for finding out my patients. So that was the time. And, these patients told me that nobody wants this kind of child, even if your mother would ask when this baby is going to die. And that was such a hard fact of life, that all the love you think of a mother coming out with this thing. And that was something, which really I still remember her. So it motivates you that you have to work harder, so that no other mother says you the same thing.
I'm sure some of your the babies have grown up now to be in college or something, and they probably
Yes, yes,
come
yeah.
back and see
They
you
do
again.
come.
Yeah,
Yes, they do come.
that
Some
must
with
be
genetic
fun.
disorder, some with genetic disorders also, and they would come, and I would find them as normal as anyone else, with few, because many of the all the genetic disorders are not mental subabnormality, right? So some of them, they are as normal like me and you. So they will also come to me, and we will share all those, that what informations they got earlier before visiting us, and we would laugh at us. We will share all those, so it's a
So, can you share any interesting tidbit from either your patients or your patients'
Yeah,
children?
recently, a girl with, Turner syndrome. And, so as you know, in the Turner, they would be small and they will not be having some periods and all. So this girl with came up with that only. But when she came to my room, she was taller than me. And, so hard to believe that she's the, then we know that the Turner will have, low IQ in maths. She was studying maths only. So everything all opposite. So now when she comes, now she has also read all about herself, and the only problem she has got is of the amenorrhea, the periods. The rest all, she's perfectly fine, doing so well in her, academics, in her life. So the mother is saying कि मैम हम तो नाम ही भूल गए उस बीमारी का, कि वो बीमारी का नाम क्या है.
अच्छा.
And that this is perfect. Now they have adjusted so well. So had it been in the pregnancy, I would have advised them to go for termination. But here is a girl who is full of life, enjoying everything, not at all worried that, she has got some problem which has made her handicap or which has depressed her. Rather, before she came, she was more, less confident. But after her diagnosis and the treatment, she is doing very well. So, these are the moments of joy when you share with the patients, when you laugh that, we have overcome, this stigma. And so that gives a good feeling. So
That's
we keep,
amazing. I think, we often say, right, like genetics loads a gun, but I think, and lifestyle, but in this case, I think treatment has, uh,
yeah,
yeah.
there are many
Mm.
disorders for which treatment management is available. So they will behave as normal as like anything. Many of them are even unaware till the pregnancy has happened, and then you will get to know, oh, this person has got this syndrome, this person is, and they said, see, all throughout life I had just mild autism. I never knew that I have got this, and well educated, doing well in life, and then so thank God they didn't come to me during pregnancy. So you know so there are a lot more to be known, that where to advise abortion. There is so much wide spectrum I see every day. So there is no, black and white line in the prenatal diagnosis. Many a times you are clueless what to say, that what are the, the baby is going to behave, whether the baby will be entirely abnormal, or it will be entirely normal, or it will not affect nothing. So there are many things, which gradually I'm learning through this, working with the women who come to me for prenatal diagnosis for whatever reason, or families which are coming for the pregnancy. So with the genetic disorders. So, it's a great learning. And
That's amazing. So you also mentioned about like people with older age women who are having babies. There's also a lot more people who are freezing eggs and or doing an IVF and things like that. Do you think that because of that there are more people who would have to see fetal medicine experts because and is there first of all more chances of genetic disorders or anything else for those kind of patients who are
the
looking at IVF for
yeah,
other options as well?
the older age women, they do have more chances of aneuploidy, like Down syndrome, then Klinefelter, yeah, this triple X. They have more chances. So, of course, thanks to NIPT, the non-invasive prenatal testing, which we can, detect through after NT scan. We ask them to go ahead with this testing, and if that is high risk, then we do the amniocentesis to confirm that yes, this is Down syndrome or whatever, Klinefelter. So these are the, then regarding the IVF, the worldwide literature has shown that, there is not significant increase of the aneuploidy or other genetic disorders, and except that they do say that the Beckwith-Wiedemann syndrome, that there is an increased chances in if the women undergo through the IVF, because this is the epigenetic process, as you discussed initially, that the epigenetics part, because of that, the epigenetic dysregulation in the IVF, some of the children born may have Beckwith-Wiedemann syndrome. Otherwise, per se, the literature does not support that IVF has got increased all these abnormalities, the cardiac or neural tube defect. I feel that in IVF, the abnormalities are highlighted more because these were the most wanted babies,
Mm.
and on the top of it the problem has happened, so this will be highlighted more genetic testing will be done to verify that yes, this was genetic, so as to give them the closure. So otherwise the literature, other than the Beckwith-Wiedemann or the epigenetic disorders, does not support others.
It's probably because we are testing more, we also find
Yeah,
some.
we're finding more. Yes,
So
yes.
one question I had, how come all these names of these syndromes are always on some English name, right? Like, do we have any that are like Indian discovered rare diseases, or that's not doesn't happen?
No, I think Dr. Shubha had one,
Yeah.
not on her name, but there is one disease, some skeletal dysplasia. So
I
in
think
the name of
last
Auntie
week also
Judy.
I was
Yeah,
talking to Dr. Ashwin. He also mentioned some,
yeah, yeah.
but
So she has also got, but till now we haven't been able to, get anything in our name. I'm sure with so many genetic testing in our country,
I'm
the
sure
future
you'll
is
be
bright.
there. You'll hope maybe there will be one that
Yeah.
will be on your name soon
Oh,
enough. So
oh, I will be more than, you know, excited to know about it. But yes, I do dream like that, that maybe something in my, I may find out some, signs or something which I can put in my name, because after all, you don't work for the prizes, but prizes will motivate you. So
So I also read about what they call as the vanishing twin, which I was quite intrigued by the term. So
yes.
is that something that you do? I mean, do you see
Yeah.
or do often or?
Yeah. So the vanishing twin, yeah, as the name is already suggesting, it is vanished. It was there
Mm,
initially on the initial scans, but over the subsequent scan, that has vanished. So why this is important? Because at times it has been seen that this vanishing twin may have some aneuploidy, and
mm,
that's why this has vanished. And also, if the twin has vanished, then the dual marker, there will be a difficulty in doing the interpretation of the dual marker, because the papae of the dead twin will be remain higher for quite some time.
I see.
So that will impact the biochemistry. So they say that whenever there is a vanishing twin, if there was a cardiac activity present initially in that twin, better not to do the dual marker. In that case, only the ultrasound markers should be done for the prenatal screening for the Down syndrome. And thanks to NIPT these days, that after the vanishing twin diagnosis, we can do within, there's some, the 8 to 12 weeks after, we
Mm,
can do the NIPT, although the chances of false positive will be higher. But we have seen cases that this was an IVF case and there was a vanishing twin. She came to me with a dual marker positive. So I
mm,
said, okay, in the first place, this should not have been done, because this was, and then most likely this is vanishing twin trying to, IVF, you have to cool them till the time you can do the prenatal testing. I said, okay, we'll do the amnios. Then we did the NIPT, that also turned out to be positive. So we counseled her, assured her, no, 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 this is all vanishing only, don't worry. So we will do the amnio and it will be sorted out. And this amniocentesis reconfirmed that, actually the normal baby has got this Down syndrome. So the role of NIPT is here as well. So that's why I say it's a very good test. You just have to know where not to do, which
mm.
you have rightly picked up, that I'm very, keen to let the public know, that my colleagues know that where not to do. Otherwise, you use indiscriminately, but there are certain reservations where one should not do. Then, there will be a false assurance in those cases. So it should not happen.
So over the last like 25 years or so since you've been doing this, clearly I think a lot of changes have come in terms of turnaround time and all. Where else do you think genetic testing should head towards so that it can lead to better patient care or better utility for doctors like yourself?
Yeah. So, the biggest thing is the genomic data. And the second biggest thing is the HPO phenotyping. So the more deep phenotyping we are able to do, they will have more, the results. And what I find that, the many a times, why I don't find the answer which I'm searching for, because there are two people. The one part is the lab scientist and the other part is the clinician. So the lack of coordination between them, because they are not trained for that, and the clinician is not trained for the bioinformatics. So I am looking for the era where a clinician will be trained in both, right? Knowing the bioinformatics also well versed, then of course the clinical part also, then only the results of, because as you know, these exome sequencing data, they are very, very, enriched. It's just that you have to find out them
Yeah.
depending upon, whatever the correct terms are given there, then only it can be found out. Because sometimes on first result we don't find anything, then we ask them for reanalysis based upon our HPO terms, new phenotype, and then the result would come up. So yeah, and many of these uncertain significance, which are particularly important in the prenatal setting, that they don't tell us, because this is variation of uncertain significance. And then after the pregnancy, when the baby is born, the baby has the same phenotype as per the VOUS. So these are the things which I feel that, in the current times, it's more for the analysis part, interpretation part, where I'm finding the problem. So the clinicians, they don't know much about it, and bioinformatics is very, very vast. So that gap is very, very wide, and that will take some time to fill up.
True. I think so. From our side, I think we have a medical geneticist now on board. We have counselors, but I think it's still. You're right. I think there's a lot more that we need to do to reduce
Yes, so
that gap.
interpretation of
Yeah.
the data is a big challenge in the times. Otherwise, the tests are being done in time and everything is being done. The many a times we are not finding the right answers, and so in the second analysis also, third analysis also. So that will take some time, but we are doing quite. I'm happy the pace with which it is growing, the bioinformatics and all. So doing lots of advantages to the health and disease.
So what exactly is fetal therapy? Is it like is that a term different from what we have just discussed in terms of what you do for the fetal, or is there that is a very specific area of what you do?
So basically, the prenatal diagnosis is diagnosis part only. So for like Down syndrome, thalassemia, they would diagnose. Then the fetal therapy is, suppose there is some problem in the fetus, then it could be medical treatment also. It could be surgical treatment also. So medical treatment, like suppose a baby, I have done the prenatal and find out that this is a congenital adrenal hyperplasia. There is a family history. So then I would do, before I can do the CVS, I put then on the treatment so as to avoid the virilization of, in case the female fetus is a female and affected. So then these are part of the medical therapy, and so then comes the surgical therapy, or the like intrauterine blood transfusion in the mothers who are Rh negative, and those who have antibody positive, which we call as Rh isoimmunization. That forms the major part of the fetal therapy in our center. I'm involved in that, but directly I don't do it, but it's amazing results. Very few failures, or I should say very few side effects, like and the baby is doing very, very well after the birth also. So that has really revolutionized the fetal therapy in India. Earlier it was only available at AIMS, and as you know, the workload of AIMS is already very, very high. So the and unable to reach, that appointments were lacking, and in the meanwhile the fetuses were deteriorating. But now with the availability of many private centers in Delhi and around, the fetal intrauterine transfusion is the biggest thing which we are doing as a fetal therapy. Then few centers are working in this twin pregnancy treatment by the laser, by the cord coagulation. Then there is another fetal reduction. So where if you have like three fetuses, then nobody want, and also the outcome is worse if there are three fetus triplet. So then one fetus will be given KCL. So these come under the therapy. So they are treating the fetus, and not, diagnosis is a different part. In case you, before treatment, you want to do the treatment of the diagnosis also for Down syndrome, thalassemia, whatever, as per the history, then that can also be done. But these are basically for the treatment part. So
So, so you think that patients are quite happy with when they know that there is a possibility of treating them. So it's not something that is like a Down syndrome, but some of the conditions that you just
yes,
described.
yeah,
People are willing to then go
yeah.
through that. But this is available today in a few centers across.
Yes, yes, this is available. So actually, for public expectation for any treatment, is there any treatment available? If you do diagnose, their question would be that if you suppose the baby has got Down syndrome, will you treat it? So then why you are doing the prenatal diagnosis? Their question would be why you are doing. So then I have to tell them that this is also a form of treatment or management only. That I'm telling you that this baby is affected, so that, so as to avoid all those burdens. So the public expectation from us for is always any kind of treatment. So so they are more than happy when they get to know that, and of course these treatments which I discussed, they are expensive, but still they would arrange, and they'll go ahead. So usually in few cases you will require 2 3 transfusions. So but still, if you find a healthy baby at the end of the so much expenses, so it's nothing like that. So these
I think people have to see the cost in the
Yeah.
beginning will be much lesser than what you would probably have to do
Yes.
later on in life. So we went through fetal diagnosis, we went through fetal therapy, but many times, let's say there is a baby doesn't survive or has to be aborted. Do you think parents are okay with getting a more detailed analysis of that? We often see some of that, in terms of testing, but how do most parents, I mean, is it like 100% of the parents are okay with getting an autopsy or of the fetus done, or is it still very, very few people who would like to know what went wrong, if something did go wrong?
Yeah. So, whenever any, particularly the intrauterine demise occurs, the first question the parents would ask, what went wrong?
Mhm.
And is it going to happen again? So these are the two important questions they would ask. So, initially when we used to tell them, then there were lots of, the couple would refuse that, no, no, we don't want autopsy. It is quite disfiguring. It is not acceptable. But gradually, when we started telling our colleagues that these are the advantages, talk to them that the diagnosis can be done in about 70 to 80% of the cases. And even if we don't find the diagnosis, this will help in the management of the next pregnancy. So I have realized that, it's how you communicate to them. That is the most important part, because after all, they are only who are looking for these two answers. Why did it happen? Is it going to impact the next pregnancy? And the autopsy can give the answer in the. So once they are convinced, so now they are, I can say 90-95% would agree. Those who are not agreeing is because of the cost.
Mhm.
Otherwise, the transportations and everything is now, the system is in place, that the fetus can be collected, how to send the fetus, where to send the fetus, and all these is already, the system is there. So very few of them would, say no to the procedure. So it's just that we have to inform them. So that is, now I'm finding that they were not informed. So that part is, more, rather than the couple refusing. If you tell them properly, they would listen.
That's great to hear. And we also see that, I think, although I remember the first time when I wasn't very educated on what that was. And so they called it a POC, I think the POC or something.
Yes, POC.
From my background, I think POC meant something completely different. So I
Okay.
was confused.
So
And
what is it? Yes, the product of conception.
yeah,
And that is quite commonly, because we need to find out the answer. That gives a closer both to the obstetrician and to
result.
the patient as well. So it's very, very important. So, and now when the genetic testing is available at your doorstep, then one must inform. And the cost has gone very, very significantly down. It's within the reach. And there are multiple tests. You can start for the as low as the QFPCR, not necessarily microarray or whole exome sequencing. If you're suspecting T13, you can only diagnose on the basis of qPCR, just 2-3,000. So it's just that you have to communicate to them. And if nothing is possible, at least DNA storage can be done. Later on, when they reach to some geneticist, and then that DNA can be utilized for the further testing. So a lot has changed, lot have changed, which has helped us in managing the reproductive group, with the pregnant women, their ongoing pregnancy, past pregnancy mishaps. So a lot has changed, the outlook, the knowledge, attitude. So all towards the positive aspect only.
That's fantastic. I think we've covered a lot today. I think I've already taken 1 hour of your time. So I do have the more fun part of the Gupshup left. So I hope we can spend another 5 or 6 minutes just discussing some fun things about you as well. So first of all, thank you for all the knowledge that you give us. Can you tell me if there was one thing that you would have done if you were not a geneticist or in this field in the OBGYN space or fetal medicine, what would you have done?
I would have done something in the medicine only. I had no plan other than so
Okay,
somebody asked, I said I wanted to become a doctor. Why? I wanted to become a doctor. So the same
that's
was the
clear then.
question.
Yeah.
Yeah.
So, what do you like more, tea or coffee?
Oh. Now it has changed over the years, coffee.
Coffee. Okay, great. And any fun story that you can tell us over the years, if there's something funny that has happened
Yeah.
treating patients or
Sometimes, the absent nasal bone is a marker for, Down syndrome. So when we do amniocentesis and confirm that there is no Down syndrome, and then the family would tell us that if there is no nose, how the baby is going to live? So they think that absent nasal bone means absent nose.
yeah.
So, that is, and that's a very common, mistake which the patients would make. So that always makes us
That's
laugh,
fine.
probably on us only, that we were not clear that this is the bone only which we are meaning. We are not meaning about the actual nose. So these are.
That's funny. Yeah. One more thing. If you had to make your life, or you've treated so many people, can you correlate it with any movie or a book or something that you already have read?
Not exactly. I plan to, maybe one day I can write from my diary, something like that. My experiences with my patients, they are really fantastic experiences, and they will definitely, turn into a big storybook. And people would love to, read these real life stories. Many of them would touch you, when you talk to them, many of them would, change you as a person.
I
So
agree.
dealing
I
with
think
public is very, very satisfying, I must say. You get to come across all sorts of people, and majority of them are good people only.
absolutely. I think no, you have made such a big difference in so many people's lives that your book would be an amazing treasure trove to read for
Someday I
everybody.
feel, that I will find some time and will put pen down these, feelings and some stories, so that,
You have to take out some time off from your busy time to
I take help from you.
yes. So, anything else that you would like to tell, the viewers, what should they, just some advice to them in terms of if they are planning a pregnancy or anything else that you would like to.
Yeah, so the pre-conception visit are like a health checkup. They must, start doing these pre-conception health checkup so as to find out that what disorders can be prevented, what are the ways to prevent, and so that will help them in achieving a healthy pregnancy. They have to plan in time, and with certain folic acid supplementation. So that is the most important part, and visit their regular, both the obstetrician and the fetal medicine doctor, those who take care of the fetuses.
I think that's sound advice. So, thank you so much. एक question और रह गया. What do they call a fetal medicine doctor in Hindi?
Oh. Okay. So I I think Bhrun Chikitsa. Uh,
अच्छा.
so maybe.
I don't know. I was just thinking just now. I was like, I don't know what they call.
So
What,
prenatal diagnosis we call Bhrun Chikitsa,
hmm.
like that. So maybe Bhrun Visheshagya, like that, the prenatal specialists. So, like that.
That's good. Anything you'd like to say in Hindi for people who don't understand English? क्या करना चाहिए?
सो सबसे इम्पोर्टेंट एडवाइस तो प्रेगनेंसी प्लान करने का ही है, बिकॉज मैं प्रेगनेंसी के क्षेत्र में काम करती हूँ, एंड एक्चुअली जेनेटिक डिसऑर्डर का कंट्रीब्यूशन मैक्सिमम ड्यूरिंग प्रेगनेंसी एंड चाइल्डहुड में ही है। तो प्रेगनेंसी प्लान करके अपने ऑब्स्टेट्रिशियन से मिल करके, फीटल मेडिसिन स्पेशलिस्ट से मिल करके क्या सलाह लेनी चाहिए, ये जरूर करना चाहिए। इसको एक हेल्थ चेकअप के जैसे इस्तेमाल करना चाहिए, जैसे हम लोग बाकी अपने हेल्थ का ध्यान करते हैं, उसी तरह से अपने फीटस के भी हेल्थ के लिए प्री हेल्थ चेकअप करके ही प्रेगनेंसी प्लान करनी चाहिए।
Thank you so much. Thank you, Dr. Seema. That was amazing, and really very happy that you could find the time to talk to me today. I think it'll help so many parents and other viewers to just know what they need to do about this. So, thank you so much. Thank you for making it simple. And I know we could talk for many more hours, but I think for now we'll end that and let you go and get your dinner and so on. Thank
Thank
you.
you. It was lovely interacting.